Hi everyone, welcome in Meet&Share, in Cancept Meet&Share. We're really happy to have you today. Bonjour à tous. On est ravis de vous recevoir pour notre Meet&Share de septembre. Ça n'a pas démarré? Les gens se connectent. Ouais, c'est parti, c'est pas. Bonjour à tous ceux qui se connectent. Bienvenue au Meet&Share de septembre, Meet&Share de Cancept. Nous allons parler des données de prévention au Canada. On va attendre quelques minutes que tout le monde arrive. Et on pourra commencer avec Béatrice qui présentera le réseau et Darren Brenner qui présentera la présentation d'aujourd'hui. Merci à tous de vous être connectés en cette période bien chargée du mois de septembre et en soirée. Et on vous enverra bien sûr le replay très rapidement après. Et n'hésitez pas pour suivre nos activités de Cancept à nous suivre sur LinkedIn où on poste régulièrement les nouveautés de notre réseau. La présentation sera en anglais, mais n'hésitez pas à poser vos questions en français. On répondra dans toutes les langues. Je pense qu'on va commencer. On va peut-être commencer. Je vois que le nom se stabilise. Donc, merci beaucoup à tous de nous avoir rejoints pour ce Meet&Share. Et on va commencer par une présentation de concept par Béatrice Fervers qui coordonne le réseau. Et ensuite, nous aurons la présentation de Darren Brenner sur les données de santé et de prévention au Canada avec l'étude Compare. Et puis, n'hésitez pas tout au long de la présentation à poser vos questions dans le Q&A et on y répondra à la fin. On aura 15 minutes pour répondre aux questions tous ensemble. Donc, je vais laisser la parole à Béatrice.
Merci beaucoup, Pauline. Et donc, à mon tour de vous souhaiter à tous la bienvenue pour ce Meet&Share. Aujourd'hui, pour le mois de septembre, à un horaire un peu inhabituel. Et j'espère que vous avez néanmoins tous eu la possibilité de vous joindre à nous. Donc, on a un immense plaisir d'accueillir aujourd'hui Darren Brenner. And I will switch to English to welcome our colleague from Calgary, Darren Brenner, who is Associate Professor in the Department of Oncology and also Community Health Sciences at the University of Calgary. And he is also the coordinator of the COMPAR study, which is a Canadian study working the COMPAR Canadian Population Attributable Risk of Cancer study, and which is looking into attributable fraction and the benefits of prevention action. So we are very pleased to welcome Darren Brenner for today's conference. And as usual, and I will do it in English because most of you now know what are the aims of Cancept in French language. So the Cancept Network is a national network of 6 academic partners and 1 field partners, bringing together more than 10 scientific key disciplines in the field of cancer prevention research. And the network aims to develop innovative research projects addressing the current challenges in cancer prevention and to improve the translation of current knowledge on risk factors into cancer prevention strategies with a specific focus to overcome fragmentation in cancer prevention and to better link the different steps and components of cancer prevention, but also to bridge the gaps between the community and population approaches and more clinical prevention services dedicated to people at high risk. Next slide. So these novel approaches are grounded in different research disciplines, but also field expertise and stakeholder knowledge, because the partnership and involvement of stakeholders, being this public, being this sometimes patients, but being this also actors of public health policies, is one of the key aspects of the Cancept network. And this will be is developed through 3 different types of activities. This is working together on a more theoretical basis to develop a shared conceptual framework among these different partners, to develop joint research projects, to implement these conceptual frameworks, and also to have networking activities among the partners, but also in a wider community. And our session, Meet and Share, Cancept Meet and Share today, is part of this to contribute to developing capacity in cancer prevention research. So the 3 major themes in this network is a participatory approaches, is the exposome approach, which also involves using of biomarkers in cancer prevention, and the approach of planetary health, bringing together nutritional approaches on the environment, and how we can favor prevention activities which address both the lifestyle, in particular nutrition, but also the impact on the environment. So this short introduction and stresses the importance of the presentation we have today by Darren Brenner on how we can better assess the attributable fraction of different risk factors, and also the potential benefits of some prevention actors in this field. Darren Brenner, the floor is yours.
Thank you very much, Beatrice, and thank you for the invitation to share some of the work we've been doing in Calgary and with our collaborative team in Canada. Hopeful that that's showing up okay.
Yeah, shows up very nicely.
Excellent.
Right.
So what I thought I would do is sort of show some of the work that we've been doing in our team with this framework that we have to try to use data to try to generate impact. And when we say impact, what does that mean to us? It means, well, that people are seeing with their eyes, hearing with their ears, and we're trying to make impact at either the personal level, at the public health level, or hopefully in some cases, even at the policy level, which I'll show a few examples of. And so in addition to the COMPARE project, which was the Canadian Population Attributable Risk of Cancer, I'll show some of the other work that's related that we've been doing to try to sort of build the data infrastructure, build that sort of validity of the work that we're doing around different projects, to have this concerted effort and concerted pipeline from data using high quality analytics to generate evidence. But we don't just stop with publications. We still do them because it's important and it gives that level of peer review and rigor. But everything that we do now, we take to the next level through either knowledge translation efforts, public facing activities, public facing materials, and sometimes medical and policy facing materials. So I'll walk through a few examples, spend quite a bit of time of the talk on the COMPARE project, but also give a few other examples. And so myself, I'm in a clinical department at the university. And so a lot of my colleagues are sort of really end goal focused around patient care. And a lot of the meetings that I'm at in national stakeholder meetings, it's really hard to continue to make the case for cancer prevention. Unlike treating patients in the clinic, where it's sort of a very short, narrow time window, and a lot of the research, you're able to show that impact. Prevention is challenging because the time horizons to show from change to impact goes beyond even some people's careers, but certainly goes beyond political cycles of funding. So it's hard to get that investment to really make that impact. So with that in mind, we tried to sort of start thinking across this cancer control spectrum. how do we do work that's impactful across all the way from, the earliest exposure of diseases through some of the studies that will show and try to reduce risk of cancer through modeling and understanding impact. So this is really some of our compare work. How do we improve prevention through secondary prevention of cancer through early detection and screening? And again, I'll show some examples using data. And along with my clinical colleagues, we also have some work where we're trying to improve and using data with patient data, understand modeling and improving those outcomes. But today I'll just focus on these sort of two more what we think classically of prevention in the primary sense and a little bit of data focused work in secondary prevention. And so jumping back to that point I was making around how hard it is to sort of articulate the case for cancer prevention. It's sort of obvious why it's important to do, but it's kind of challenging to show tangible examples of how investment and effort across the levels of people, policy, and public investment has made an impact. So myself and my colleague, Matt Workington, we wanted to sort of use some data to try to make this case to show no, everything that we've done so far has had a tremendous impact in Canada. And so we came up with some estimates of what we were calling avoidable mortality to show how we've made an impact so far in cancer control. And so we were able to say that in Canada, cancer control, and in this case, largely prevention efforts, have already averted over 500,000 deaths. And so, how do we come up with these numbers? And so, we were able to access mortality data, site specific cancer mortality data, and look all the way back from 1950 through to 2022 and model out what would be if we look at what the highest years of mortality were and if nothing changed. So we assumed those high mortality rates would have continued and then we project forward based on how we know the population has grown and how the age structure of the population has changed. So the red lines here, for example, on the left for lung cancer. So the solid line is among males and the dotted line is among females. The red line shows what would be the impact had nothing changed. So post the peak mortality levels in the early 80s for had we not have any implementation or advancements on tobacco control policy, that's how many people would have probably died if nothing changed. And we've done this across all cancer sites, and we're able to look across this. And that's how we come up with these, what we think are very impactful numbers when we go to funders or we go to the government to say, look, what we've done in the past was really important. And there was a little bit of investment that was made to support that work. And it has had a tremendous impact. And so these are examples where, so for tobacco control for lung cancer, and so in this case, infections and food control policies and food storage policies for stomach cancer have had a huge impact in Canada over the last 50 to 70 years. And similarly for screening, we can advocate that this is really working when we look for cervical cancer on the left. So we can see that, since mortality peaked in the late 40s and early 50s in Canada, we've had a tremendous amount of avoided mortality, a lot of this very premature mortality as well for cervical cancer and for breast cancer on the right. So this is just some ways that we're trying to, again, use data to make impactful messages to sort of get people thinking both the personal level, wow, this it actually can change the future, save lives, and that investment from the policy side can have a huge impact, even though we can't see it within a 1 or a 2 or a 3 year funding cycle. And so that's some work we've done sort of to help that message go forward. So again, using data to generate sort of impactful messaging for people, policy, and the public. Over the past 5 years, I've had the amazing pleasure to work with the Canadian Cancer Society, which is our national patient advocacy and fundraising group in Canada. And as part of that, I've been the co-chair of the Canadian Cancer Statistics Advisory Committee, where we generate these really large reports around the cancer impact in Canada in terms of incidence, mortality, survival, prevalence. And then we try to focus on some specific high interest topics around cancer prevalence, survivorship. And again, I show this to say that this is another example of using data to really drive impact and awareness. because most of the time when these have come out, we have had a tremendous amount of media attention and public attention. So the media is the numbers on the top. So these are just a few examples. So a media hit is like a newspaper article or a TV spot or a radio interview. And then the number below that is the number of times that people have seen these things or heard these things. And so when we think about creating impact, you have to create awareness through, information. And so each time these get released, they have, tens of millions of times people's eyes and ears hear them, receive them in Canada. So for us, this is another really good example of how we use data to drive impact in Canada. And as part of this, we also want to try to make this available. So for a bit of context, Canada is sort of an interesting situation where we are a federation of provinces. So there's 10 provinces and 3 territories. And so because of this, we have this sort of very fragmented way in which cancer control is delivered. So even though everything's funded federally, the provinces have to sort of manage their own cancer systems. And so, as part of that, there's some that have a hard time keeping up on information. And so, we try to help this by creating resources for the provinces and the territories to be able to access these data quickly. And so, as part of our sort of commitment to not just have these reports and publications, we've now created a data dashboard, our Canadian Cancer Statistics data environment, where people from the provinces can immediately pull down this information. Anyone who is sort of interested within the public has access to all of these data. They're very customizable, and then people can use them. So whether you're interested in a particular cancer site or a particular group of cancers, what's my expected outcomes for these groups? And so this is just sort of a visual sort of showing what this looks like. But it's kind of our continued commitment to sort of say, okay, we can generate all these data, these estimates. Let's try to create impact. Let's try to create awareness. And how are some of those ways that we can go beyond our traditional publications to sort of make some impact for people in Canada? And I would invite, if anyone's interested, the website is cancerstats.ca, and we update this every year with the most up-to-date data. And so again, this was our efforts to build this dashboard, and all of this work. Everything I showed today is the efforts of not just me. It's a lot of people, a lot of team, and a lot of highly dedicated individuals. In this case, it was my colleague, Dr. Gerada, and Ned from our team, who really built a lot of this material going forward. And again, we're going to keep this moving and updating it and adding to it. And eventually, our hope is that we can also continue to add some more prevention data to these types of resources once we've built the infrastructure, built the validity and that sort of trust with that data source. And so as part of this work with the Canadian Cancer Statistics, I get to the sort of interesting pleasure of tucking into all of the detailed trends in the cancer data in Canada. And over the past about 10 years now almost, I've been really interested in the rates of early onset cancers for breast and colorectal. And here I show the incidence rates among, so these are people defined by when you were born in Canada. So each of these are 5-year birth cohorts. And this is among all women in Canada. And so what you'll see is that there's been this sort of dramatic uptick in cancers being diagnosed among people born in more recent cohorts. And this would suggest that there's some epidemiologic phenomenon that's been going on. And so, again, just to sort of keep the theme of the data, the analysis, and the impact, we've been working within our cohort studies here in Canada to try to understand what is it? What are the particular factors that are driving it? So we did what's called a nested case control study, where within this big cohort study of over 300,000 people, we identified those cases that were early age at onset, so before age 50. We matched them with the appropriate controls, and then we did some analyses to try to understand which of those risk factors are potentially driving that association. And what we found was that it has a lot to do with, at least in our cohort, and this is in agreement with what's seen in the literature, measures of socioeconomic, so health equity, seem to negatively impact cancer risk. measures of reproductive history, and then perhaps the most relevant to the cancer prevention message is the measures of excess body size and energy imbalance seem to be driving this risk. And then we did a follow-up study where we looked at the biological markers of inflammation and insulin resistance, which are typically measures that are dysregulated with situations of energy imbalance or excess body size. And we saw a pretty strong association with both of these and increased cancer risk among younger people. We also have done this now for early onset colorectal cancer. And this was work that was led by then postdoc, now scientist, Dr. O'Sullivan on our team. And we're taking this further to try to understand, okay, are there other emerging risk factors that we really haven't historically studied very well, and working with the cohorts to try to augment our data collection to understand these things. And so as part of this, we also try to work with patient advocates and patient support groups to try to making sure that what we're asking, the way we're asking these questions is important and impactful to them. And so we've been working with groups like Colorectal Cancer Canada to conduct some patient and caregiver surveys to try to understand what are the priority research questions, or what are those points of interest for these particular patient groups and families. And we found this to be very important for our work to make sure that it's asking the right questions to try to help those patients and patients in the future either reduce their risk of incidence or second primary cancers in the future. And so all this to say, we've tried to building a track record of using these data, these analysis approaches to try to build evidence that can be turned into something impactful through different approaches and strategies. And in those cohort studies, we identify things that increase our risk of cancer. But we've kind of always started with the mentality that it's probably not enough to just say this increases someone's risk of cancer. That's a good starting point, but it's probably not enough. And so this premise is what became the genesis of the Canadian Population Attributable Risk of Cancer, or COMPARE study, where we kind of wanted to build a framework to understand if we took all of those risk factors that we have a strong belief and a strong evidence base that they do in fact increase our risk for cancer, what would be the current amount of cancer that's probably due to past exposure? But that's happened. It's important to understand that there's not necessarily a lot we can do to change that. We can help support that, but what is probably more important is if we could change the prevention right now in terms of defining some prevention strategies. So that blue arrow, and these is when we started this, which was sort of the late 20 teens. What would be that future avoidable impact of cancer that we could potentially try to bend the curve? So with our populations, I assume similar demography is happening in France, where the population is growing and it's getting older. So those curves just keep going up and up in terms of cancer incidence. So what could be the impact in the future? Could we bend that curve going down if we could implement some strategies? And the first thing we need to know is what would be that impact? So what would be the return on investment? Because everything's going to take work, everything is going to take investment. So what would that look like? So we set out and did a very comprehensive methodologic framework to systematically identify these risk factors, come up with rigorous data sets that are nationally representative, and then pair that with sort of the most valid approaches to project cancer incidence and mortality forward, and then understand the potential impact fraction. So how much proportionally and the total numbers of cancers over the next 30 years that could be prevented if we did something now. And so as part of this, so this is a snapshot of what we found, and we generated a tremendous amount of data for this study through this framework. And so on each color, these shows you some of the most important risk factors, important in terms of the impact that they have on cancers in Canada here. And these are the highest proportion attributable cancer sites. And so what you'll see here is you've got 9 cancer sites. And there's kind of 2 key messages that come from this. One is there's some risk factors that maintain their impact and they're impactful across all cancer sites. And so this is like smoking. So the red bar here, you see it has a pretty strong impact across many cancer sites and continues to. So additional action there would not only have impact on one cancer site, but it would have a broad reaching impact in cancer control. And so that's an important message to sort of go to policymakers to say we need to invest further in these strategies to reduce this because it would infect all of these cancers and would have a dramatic impact. Others can be more focused, for example, H. pylori infection. So this dark blue for the stomach cancer, so the second bar on the left, has a huge impact on stomach cancer in Canada. So focused effort is valuable and would have a dramatic impact on one cancer site. And so how do we come up with some strategies to try to focus on this? What are the right places to do that, to sort of try to intervene? Who are the right populations to target? And so we generated all of this. We generated an entire series of publications that was in preventive medicine in 2019. But again, with that paradigm and that framework of data to impact, we didn't want to just sort of stop at publications. And so we generated multiple social media campaigns, multiple materials that are directly, specifically designed for social media. We came up with a whole brand identity for the project. And we sort of had multiple years of rolling out just, on a regular schedule, more information around cancer prevention through these two platforms that we built in partnership with the Canadian Cancer Society. One was prevent.cancer.ca, and this was our online website where we had all kinds of materials. We developed a cartoon video around sort of what we learned from the study and what we can tell the public around cancer prevention. And then we also, for those who are sort of interested, generated a series of data dashboards where we could look at all of these different data that we generated. And these are at data.prevent.cancer.ca. And they're pretty nice, clear, clean visuals that show both, the current burden, so what is important now in terms of those cancer cases being currently diagnosed. And then, also what is pretty neat is we have some projections around the future. And in that, we give different, what we call counterfactual scenarios. So a counterfactual scenario is what we could think of as like a prevention target. So if we could reduce tobacco consumption by 10%, by 25%, by 50%, because we know that in the hypothetical situation, it would be great to remove a lot of these exposures, but that's not going to happen at the population level. So what are some incremental changes we could make that, and what would be that subsequent impact? And so again, we did this for all cancer sites, and I'll show another example of this in a moment. But again, just trying to show how we've been taking our analysis and trying to add levels of knowledge translation, knowledge generation, and engagement with the public. And I think it's been a really rewarding experience because when I see these types of things, I have had, this was a few years ago now, but these types of, on the left-hand side, these are some of the infographics we generated. And each of these little squares have been used as different Instagram and Facebook posts and things like that. And it was really neat when my niece, who is in high school in a different province, so she lives about 3,600 kilometers away, sent me one of these. And she said, "Hey, have you seen this?" I said, "Yeah, we actually generated those." And so it was kind of great to see how that was getting through. Again, thinking about messaging, it's low cost and it's getting out there to people. So I think that's great. And on the right-hand side, these are some of the other visuals that we generated. And these are pictures that were sent to us from a primary care clinic. So basically our family physicians, our family doctors, clinics here, they had these on the table. So that is also very encouraging to us because when we set out to do the project, we set up what was called a knowledge translation committee. And we had the Canadian Family Physicians Association on that committee. So that way we could share things through them. And after the project was finished, our analyses, I gave all kinds of presentations to the different groups to make sure they could access this information and share all of these visuals so that people could have access. So in the end, we know that all of these things had over 100 million digital impressions. And so again, a digital impression is like someone seeing it on social media or somebody hearing it on the radio or on TV or on other things. We also had TV commercials that were run for a few months after. So again, very different than the kind of research that I was used to, where we have an interesting hypothesis, test it, publish a paper, and then we keep going. This was very much focused with this engagement in mind. And I'm happy to say that it's sort of the way that we typically do all of our work now, is with this focus on what else can we generate, how can we make people hear and see what we're doing, in hopes that that leads to change at the personal level, potentially at a policy level, which I'll show in a few minutes, and at the public level. So we finished this project and we thought, okay, we create all this data, but we don't want it to let it just sit there. How do we engage even further? And so we want to try to take this to some health policy. So in terms of some health economics. And so on the right-hand side here, I show that we actually, our work, this was featured in the Canadian Strategy for Cancer Control, which was a federal policy statement about, what's going to be most important. And so that's really important because it's how they're going to prioritize funding. So again, using data to sort of drive that information. On the left-hand side is something called OncoSim. And OncoSim is a micro simulation platform. So it's basically a whole suite of data tools that already is generated by the government to be able to ask all kinds of questions in cancer control. And what we wanted to do was we said, okay, can we take all of this attributable fraction data or this cancer prevention data and actually insert it into these data tools so that other people can use them too? And so after our project, we did this. And we were able to sort of show then kind of the health economics side of the cancer prevention as well. And so within these models, it will tell you how much each cancer diagnosis will cost the system depending on what stage it's diagnosed. So later stage cancers typically cost more than early stage cancers. And we know that how many, in that graph I showed previously, how many of each of these cancer types are related to these different exposures. And so therefore we can figure out how much each of these different exposures cost the healthcare system. And so you can see that these are in billions of Canadian dollars. And so this is over a 10-year period. And so you can see that it's kind of really closely related to those numbers of cancer sites. But here, I think this talks a different language to decision makers, policymakers, politicians, when we see that you can kind of make that case if a prevention program might cost X and it would lead to a % reduction in the numbers of cancers, and then that would lead to a cost savings of X, Y, and Z. It really provides a whole different language to try to talk and to try to make impact from that data analysis approach. And so you can look at this by a particular cancer site or cancer risk factor. So in this case, this is by excess body size. So this is in waist circumference. And so if we had an average, and this is a % of people going from what would be considered a high risk waist circumference to a lower risk waist circumference, 10%, 25, and a 50% reduction, you can see the annual prevented cancer costs in millions of Canadian dollars. And so we can generate all of these through that infrastructure that we've now built. And it's something that everyone else can access. It's not just our team. OncoSim is a public user interface that people can request to use and use for free. So pretty interesting way to sort of take what we've done from our research study to this infrastructure. And I'll just show 1 or 2 examples of some of the things that by doing this, by putting this in this infrastructure, and creating tools for research, it allows you to answer questions you didn't think that you were going to have. And so we were asked during COVID here in Canada, because people became very sedentary, we were informed from our government that there was an increase in the proportion of people who were gaining weight at a pretty alarming rate during COVID from lack of exercise and potential changes to diet and all of the above. But we were able to use this infrastructure to say, if people continue to gain weight and don't lose or reduce the weight gain from COVID, this could lead to a considerable amount of public health impact and also costs. And so we were able to sort of come up with some messaging to try to, get the public aware that this is happening, and so do what you can to avoid or reverse the sort of impacts of COVID on excess body size and energy imbalance. So again, an example of where we didn't even think we'd have that question, because this was all done in sort of pre-COVID when we set up these modeling infrastructure, but it was useful to do for many other things. So I'll just, before I sort of finish, I'll talk a few examples using this same paradigm of sort of data analysis, evidence, and impact in secondary prevention, so in the screening space. And so I just showed an example of the consequence of sort of primary prevention from COVID. So what was the impact of excess body size on potential cancer burden if we didn't do anything? And so we also modeled during COVID the impact of reductions in cancer screening. So here in Canada, we had about a 6-month complete interruption to cancer screens. And so we were able to use this modeling infrastructure to understand what would be that impact going forward if we don't do a massive investment of system catch up. And so what we were able to show was, there's going to be a pretty large cumulative excess cancer deaths in Canada just because of this 6-month interruption. So now happy to report that a lot of provinces are working really hard to catch up to this. And this data has been driving that push for that work are from this particular analysis and from others as well, that it's really important. So again, trying to show how we go from that data to evidence and then moving towards impact. And this was featured in our sort of Statistics Canada chief statistician's report to sort of show the importance of this. And so again, trying to think, how do we, as researchers who analyze data, how do we try to move just from generating interesting publications to making things impactful through different ways of reporting and different knowledge translation approaches. And I'll just show a few other examples. And so I showed before, here in Canada, we've had this increase in early onset cancer rates, particularly for colorectal and for breast cancer. And so on our team, we've spent the last year or so taking these same frameworks, so in this case, OncoSim, and trying to understand, can we model what would be the impact of lowering the screening age to 45 here in Canada, because we start screening for colorectal cancer here at 50. But in the United States, they've changed their guidelines to 45, and we only live 2.5 hours away. And so there's a common question of what would be the impact and what should we be doing? And so we modeled this work to understand sort of what would be the consequence. And so in this case, these are differences in the numbers of cases and deaths by age over time. So these are sort of those that would be prevented if we changed to an early screen. And so we would have about 5,000 deaths that would be prevented in Canada over the living cohorts of people from about 2020 who were eligible for screening through to 2080. But it's important that, here in Canada, we're in a fixed sort of healthcare system. So we are a single payer, or the government there's only one healthcare system. So everything has to be balanced. And so we're also able to model what would be the required immediate increase to the numbers of colonoscopies that would be done in Canada. And so here this sort of shows year by year. And so again, we've given this to all of the provinces and to the decision makers at the government to sort of understand, here's the decision that you need to make. There would be a health benefit, but we would require additional resourcing to do that. And similarly, we've also done this for breast cancer, because there's an active discussion right now to lower the breast cancer screening age to 40. And so we modeled out sort of what would be the impact on additional screens, and then also what would be the potential numbers of additional breast cancers detected by screening. And so we've basically been able to generate under different scenarios of getting screened every year, every other year, starting at 40 or 45, which are the 4 different colors. What would be the subsequent impact on the additional numbers of screens needed and additional breast cancers detected by screening. And again, this is being shared with the provinces so they can make their informed decisions to, again, go from our analysis to impact. The last thing I'll show is around health equity. And so we have a lot of issues here in Canada around inequitable distribution of health and healthcare. And a lot of this comes from basically differences in people's socioeconomic status through income. We have a very large population that live in like very rural and remote areas. So some people have to travel hundreds of kilometers to get care. And we have a very large population of new immigrants. So people who have moved here within the last 5 years. And a lot of the time, these are the prime driving factors around poor cancer outcomes. And so we've been trying to use our analysis frameworks to try to understand how can we better focus resources to identify and address some of the priorities around health equity and cancer control. And these are the 5 sort of top priorities for cancer screening to address questions around health equity. And so we're really trying to push forward with these first 2 around using data to identify and try to address those disparities, and then use those data information to try to educate the public about cancer screening. And so that public being across all segments of the population. And so this is some analysis we did with OncoSim to try to understand what would be the highest return on investment to try to increase participation for colorectal cancer screening across different socioeconomic strata. And so what this shows here is, so these are the total numbers of deaths that would be averted if we could increase participation rates to the current recommended 60%. And so because they're so much lower in low income families and households in Canada, we would have a much more dramatic impact on increasing or preventing colorectal cancer deaths in Canada if we were able to focus on those at lower ends of the income band versus those at higher ends of the income where they already have better health outcomes and better screening outcomes. And so again, trying to use our data analysis frameworks to try to better cancer outcomes through prevention in primary and secondary space. And so again, focusing on good data, strong analytic infrastructure, and then generating valid peer-reviewed evidence, but taking it to the next level. So all of this work we're generating through lots of knowledge translation and different data presentation approaches to take it to the public, the policy, and personal, hopefully, beyond just our classic traditional publications. And so to say, well, I hope that this information in this presentation has showed that data projects in the prevention space can and really are creating impact in Canada. But to have that impact, it's really important to think about some novel knowledge translation efforts and knowledge translation approaches. In our experience, continuing support for computing and data infrastructure has a pretty high return on investment, oftentimes for things we didn't even think we would. But it's really been able to sort of generate some impactful and really interesting data to support public awareness in cancer prevention. And our next steps is to sort of help us use data infrastructure to help us improve and address some of the issues around health equity in Canada, where we have some challenges. And so, the whole point is that we really need to know where we are to see where we need to go. And so we're doing that with data. Lots of people involved, but I'll just stop and say thank you.
A huge thanks, Darren. It was really interesting and inspiring. Thank you very much for that presentation. Do we have some questions from the public? Est-ce qu'on a des questions avant qu'on commence? Ah, je vois qu'il y a une question qui est arrivée. From Ni, from our Cancept network. Great and clear presentations, thank you. Great to see health inequalities mentioned and how you are addressing this as part of your strategy. Health literacy can also be a cause of inequalities, which in turn impacts education and motivation to participate in screening. Do you have any standardized data on the health literacy of the population in Provence? This is for you, Darren.
Yeah, that's an excellent question. And the answer is, I don't know. I think that's actually a great point. We haven't really looked into health literacy as one of our key metrics, but I am writing it down right now because I would suspect that Statistics Canada, our federal data agency, probably has some measures that we can integrate into our modeling. And I think that's an excellent point and a great suggestion.
If we don't have another question, I might have one. You briefly mentioned the implication of the public or people concerned by the disease in your data at some point. Oh, do you hear me well?
I missed the first part. If you could repeat that.
Yes, sorry. I was just saying.
I think we had.
We have another question, and then I will give you my question on public participation. But we have one from Suzette de la Loge, also from Cancept. Thanks, amazing. Do you communicate on deaths averted with the general public, which is always a bit strange to me? I prefer years of lifespan.
Yeah, I agree. We changed. So in our publications, we've included deaths averted. But whenever we would make some messaging, we typically use either life gained or years of life gained or lives gained.
Okay. We have also a question about having access to your presentation slides. So there will be a recording, so you will have access on everything on your YouTube channel. So I'll be able to see that again. So yeah, my question was about public participation. I was wondering whether, I think you talked about that at some point, saying that you had a questionnaire asking people about their main question they wanted to have in your research. And I was wondering whether you had other stage of participation, like more as co-researchers or different stage of participation, or I was just asking them about, you know, what they believe as being a need to be investigated in research.
So we have patient and family advisory groups that we engage with our studies. And we typically will get some letters of support for them from them whenever we are either starting a project, and then we'll define some engagement terms so that they're included. And we typically will have, if we're interested in colorectal cancer, we'll typically have patients and families that are impacted by colorectal cancer who are actually involved in the study design, to make sure that we're doing that appropriately. And then in terms of the general public, we have some work with our Canadian Cancer Society where we have a group of sort of I mean, it's hard to find anyone who's not somehow related to cancer through family or other metrics, but we have sort of more of a general prevention focused group as well.
Great. Thank you very much for your reply. And another question from Suzette, and then I will give the floor to Niamh, who also raised hands. So how do you foresee your results may have impact outside of Canada?
I think the frameworks that we've developed are very applicable. So we're working to try to come up with a standardized and open access coding framework for some of the compare stuff that others could use. So basically you have to just plug and play the appropriate data sets, which is a challenge, but it's a lot of the cancer data at least is somewhat standardized. And so I think a lot of it would be applicable to other countries, and then building the same data presentation tools, I think is very helpful and very impactful, because when you engage with non-researchers in the public sector or in government, then I think these are all what our lessons that these have been very well received.
Beatrice, I think you have a question.
Yeah, I think there was Niamh who had raised hand. Otherwise, I had a
yes, but I tried to give her. It's mistakenly raised my hand, so it's your time, Beatrice. All good.
Okay. Thank you, Pauline, and thank you very much, Darren, for this very insightful presentation of how this work, which has been also performed for France on the attributable fraction, can be used and further developed to do impactful tool also for decision in developing prevention policies and intervention. And I had in particular two questions. One, maybe to have a success story from you to how some of your modelization could or has already been uptaken by the policymakers, and in turn maybe analysis what are the barriers that this can be really implemented and uptaken by policymakers. I was thinking about one which I think may be difficult to modelize, and have your vision on this, that many of these risk factors are multifactorial, they are multi-determined, and in particular the living environment. It's not only if we think about nutrition, then of course it's do I eat my 5 fruits and vegetables every day? But it's also impacted use of the socioeconomic context. Was a question on literacy, but it's also on the environmental context. If the people have access to, well, stores who will sell fruits and vegetables. And I remember I went a few years ago to a congress in Toronto, and there was a campaign on eat 5 fruits and vegetables every day by big signs coming from the airport going into Toronto, and then went to the hotel, switched on the screen on the television, eat 5 fruits and vegetables every day. And on the Congress, there were no fruits and vegetables. And even in the hotel, this was very, very sparse. So I say, well, access was limited. Well, what is a success story on how this has really been integrated into public health decision, and is from your experience maybe also some barriers and threats for this type of approach?
So to your comment, I agree completely that the more simple or less multifactorial the risk factor is, the more success that has been observed. So 2 examples here. We have radon issues in Canada because of our geological sort of bedrock here. We have high levels of radon. And so a lot of our data was used to support building code changes. And so now they build new houses here with radon mitigation systems as part of the building code. And some of our data are cited in the actual code. So that's really easy because it's one exposure in one place, and same thing with workplaces. The second is with HPV vaccination. So we were kind of lagging behind other places with HPV vaccination, and a lot of the data that were used here were a strong driver to re-engage in the provinces in terms of increasing school-based vaccination programs, because we were able to show that it's actually a pretty short time window to those early first cases in the 30s and 40s-year-olds who would, if you don't do that right now, you're going to start seeing them in 15 years. To the barriers, absolutely. And so that's Toronto. That's our second most vibrant metropolitan center in Canada. We have thousands and thousands of people who live in places where there almost is no fruit and vegetables because it's so cold or access is so challenging. And so that's definitely, I think, the biggest struggle with any of the related energy balance and proper nutrition factors is access and cost. And so in terms of how some strategies to sort of go forward on that, we continue to think about that in terms of, is it that needs to be some subsidized approaches for food quality in school-based programs to start people younger? We don't really have a good sense of that yet, particularly because so much of the Canadian population lives so far away. I mean, having lived in Lyon for a year, you live in the most amazing place in terms of access to great food, quality produce, the marché en Essonne, and we don't have anything like that at all. So it's a real challenge here.
Okay, yeah. This is many things. I think there's a lot of food of thought. I think about another point. You nicely showed that well, you had to show the impact in terms of potential savings of tobacco. And then you had the more smaller bars, which were physical activity, obesity, sedentarity, balanced food, etc. And they are highly interrelated. However, if I put them one on the other, probably I would come even to a higher cost than tobacco-related costs. So I think this multifactorial is really a challenge in real life. And of course, the modelization is a first step. And yeah, very, very interesting. Thank you very much. I think, Pauline, there was another question.
Sorry, my mic was off. So we have one more question from Sid Nemati. Can you show how much of the mortality reduction in terms of tobacco-related cancers are attributable to improvement in implementation of tobacco policies?
So as part of that first piece that I showed around the avoidable mortality, we are working on pulling information from when specific types of policies were implemented and then overlaying them on those figures to sort of show when it happened and then the lag that happens between change, and then it will take many years until you start seeing meaningful changes in mortality, because mortality comes after incidents, and even those incidence curves take a while to bend. So we are working to sort of start showing those for both tobacco, but then also for some of the other cancers where we have known changes in policy that have impact on those cancers.
Thank you very much. Do we have any more question? One more question? Otherwise, est-ce que vous avez une dernière question avant qu'on clôt le séminaire d'aujourd'hui? J'ai l'impression qu'on n'a plus d'autres. Ah si, ça y est, une dernière question. Un grand merci de Suzette. Merci Suzette pour ta participation et tes questions actives. A huge thanks, Darren, for your presentation. I did a few communication on LinkedIn also, if some people want to pursue having questions or discussion on this subject. And I would like to use also 1 minute just to say that we have another Meet and Share next month, as every month. Normally our Meet and Share are every Thursday lunchtime, but because also next month we will be in Canada, so it will be a special Meet and Share with the les EJC, l'entretien Jacques Cartier. So we will send you an invitation to tell you the timing, but it might be also a bit different than usual because it will be from Canada. So stay tuned on LinkedIn to have the news on our next Meet and Share. And then we'll go back to Wednesday or Thursday at lunchtime for the next one of the year. And don't hesitate to follow us on on LinkedIn, sorry, or ask us question on email, and we'll be more than happy to reply about concept, opportunities, and network. Béatrice, si tu veux dire un dernier mot.
Again, Darren Brenner, a big thank you for this very pertinent and insightful presentation of what you're doing in Canada. And we would be very pleased to keep in touch, because these are very precious approaches, also what we are trying to achieve within the Cancept network. And I would also like to thank everybody who joined today in this unusual schedule, which allowed Darren Brenner to get up at normal hours in Canada. And well, we will see next time from Montreal, where the part of the Cancept team is going to meeting with teams in Canada. We will present the concept from Canada, from Montreal, to France and the wider audience internationally. Merci beaucoup, and many, many thanks again, Darren Brenner.
My pleasure.
Merci
Take care,
à vous
everyone.
tous.
Bye bye. Bonne soirée.